Don't think, there we go, okay. All right, good morning. So I have the pleasure of introducing our first speaker today, Avery LaFleur. He has been a part of the Craig family in Craig Hospital in Denver since 2004. He moved to Colorado after he completed his undergraduate degree at Wartburg College in Waverly, Iowa. So a local guy for us. After several years working in the corrections industry, he went on to get his master's degree in social work at the University of Denver Graduate School of Social Work, where he had an emphasis on medical social work as well as individual, family, and group counseling. He also serves as a professor for Metro State University in Denver. He provides educational classes at Craig Hospital in the areas of sexuality and romance, discharge planning, and social skills. Coming from a rural background himself, he understands the specific issues faced by individuals in these communities. The lack of resources, limited healthcare options, and cultural stigma can create significant barriers to accessing appropriate care. Drawing from his extensive knowledge and experience, he is passionate about developing innovative solutions to bridge these gaps and address disparities in the healthcare delivery. He is a dedicated and experienced social worker with a profound commitment to promoting inclusivity, equality, and accessible healthcare for all individuals, particularly those in underserved rural communities. By fostering a greater understanding of the intersections of sexual orientation, gender identity, and rural living, he is dedicated to promoting health equity for all. We welcome Avery up here and to share a little bit with us for the next hour. Earlier.
It's an absolute honour to be here today in full fucking glam at 8 a.m. on a Thursday morning.
Forget you don't need this one.
It is not Thursday, I know, but I had to start it off with something. Other than the fact that you're here to talk about sex at 8 a.m. on a Friday morning, what could be better than that? Except maybe being at home and having sex, right? So I kind of move around a lot. I apologize, and I'll watch. But
It's an absolute honour to be here today.
We'll move right through that again. So why do we talk about sex? Like, why is it important for people who have spinal cord injuries, brain injuries, to be able to talk about sexual functioning? There are so many things going through patients' head, and in my 25 years of doing this, I have had all the stories from the patients about when they start talking about and thinking about their ability to have sexual functioning back. Or will they have sexual functioning back? What is it going to look like? Can I have sex again? Can I get an erection? Can I ejaculate? All of those things come to mind as early as some of my patients are thinking about it when they're on the pavement, hearing the ambulance come to get them. My younger patients are thinking about that forward. Some of my older patients, I do not ever assume that somebody does not want to talk about sexual functioning. But I need to give them a pathway to be able to feel comfortable, know that it's spoken, and that they have somebody to be able to ask questions to. So it's very important to really start that discussion up front. Whether you are somebody who knows a lot about it or not, giving them the ability to be able to express that. Sometimes that comes out, and many of you, if you're working in hospitals or in facilities with individuals, they may express themselves in a way that we think is very inappropriate. They may ask, I've had many nurses say, this patient is asking me to get into bed with them and see if things work, right? And okay, so that doesn't seem probably like the best thing to say, but as a nurse or as a healthcare worker, you have the ability to take control of that and say, hey, sounds like you have some questions about sexual functioning. Let's get someone here who can talk to you about it. Or if you feel comfortable on giving some of those basics, that's very, very important. So I start out, what is human sexuality? You know, in the broadest sense, sexuality encompasses all of the attitudes and behaviors that contribute to the person's sense of being a man or a woman, both publicly and privately. Healthy sexuality represents a natural affection, tenderness, and companionship between two people. This is important to understand kind of what human sexuality is before we go into kind of a philosophy of sex, right? So people think of intercourse as the ultimate sex act, the real thing. But if intercourse is the ultimate act, then why can making out or holding hands be sweeter and more meaningful at times, right? And so a lot of times my patients aren't necessarily looking to have sex, have intercourse. They're looking at, how do I date again? Why would anyone want to date me? You know, I'm in a chair, I'm a different person. Why would my spouse want anything to do with me anymore? I'm not the same person. And these are some things that come up in their mind that we have to kind of try and settle to let them know that they are still the same individual. If they have a spinal cord injury, they're still the same person from the neck up, right? You still have feelings. And sometimes that is simply what they're looking for, is to be able to hold the hands with their partner again, something that connected them, something that allowed them to feel and show emotion to their partner that they were able to just do before without assistance. So the emotional component is just as, if not more important sometimes than the physical aspect. So there's this iceberg effect that I like to talk about. And I know I start out with this and everyone's probably itching to like see penises up on my screen, right? We'll get there, okay? I know, I see it, I see people go, oh, you said penis. I can't avoid that. This is a sex talk, right? So sexual iceberg is a kind of an interesting, like what we see is sometimes, is that important? Is that always the most important thing, what we see? Or is sometimes what we don't see important, right? And in the case of a Titanic, right, it was important kind of to like see what wasn't seen. And this is what we're doing. So I think that we put that emotional aspect below, and we just want to talk about, you know, intercourse and all those things. But if you're not feeling that connectivity, then it's very hard to move beyond and move into just the physical act, because things don't work and you haven't figured things out for yourself. So I like to move this up and get it above the surface and talk about it right from the beginning when patients come in. How are you feeling? What are your questions? What are your concerns? You know, is this something you want to talk about, right? Or is this the furthest thing from your mind right now, right? Because I've had 70-year-old patients that nothing really surprises me anymore, but things kind of take me back a little, right? So I've had 70-year-old couples in and they go, hey, we really like to talk to you. We heard you do this. Would you be willing to have a discussion? I'm like, sure. Like, let's schedule a time. Let's get together. Come to find out, they want to talk about like BDSM and leather, and I'm like, what? Like, and so I'm like, wait, well, okay, so this is an issue. We need to talk about like what that means or what that looks like for you. Because if you are using leather and you are doing like hitting each other and you have skin issues or you don't have sensation, you need to be careful. Like, what does this look like, right? Like, how do you do that? How do we, I love my OTs because they help accommodate like vibrators and things in gloves with, all kinds of cool like ways of, putting things in patients' hands to be able to have fun and enjoy and foreplay and all of those things. So that adaptation piece is so, so, so important, and not making them feel like they've just asked the dumbest question ever, right? I don't want anyone to feel isolated in that sense where they're wanting to be able to pleasure their partner, but they don't have the hand control or grip to really hold on to something. And so we need to accommodate that with a hand and putting a glove on and lots of Velcro and stuff like that. But yeah, so what we see, these are things that patients have. These are not my things, these are like patients' ideas. But I really want you to think about what it is that you see or how it is you feel when we go through this. Things like body image, clothing, hobbies, grooming, and the body language that we have. Are these any different from individuals who are able-bodied? They're not. These are the things that we all every day think about if you're dating or you're trying to impress your spouse or you're going on a date or you're going out at the nightclub. You're looking at things like, how do I look? How do I dress? Like, putting on your makeup. I've had patients who talk about how they don't want, like they get injured, they're not gonna put on makeup, they're not interested in makeup anymore. What's the point, right? Why would I put on makeup anymore? Nobody wants to date me. And so once I talk to them and say, well, do it for you. Like, don't do it for someone else. If that's how you feel good about yourself and you wanna feel good, then do it for you. Don't do it for someone else. And they start doing that and they start saying, wow, I feel a little more confident. I wanna like go out and start dating maybe now. And so this is the start of that process. So what we feel or what we don't see. Warmth, validation, connection, intimacy. Whoops, one too far. Is it delayed? There we go. So these things are things that probably aren't as surface, the things that we have to talk about. God forbid we talk, right? I mean, able-bodied individuals would have much better sex life if they just talked about what they liked and what they didn't like, right? How many times, okay, no personal, nobody share, this is not a sharing moment, okay? That gets really awkward. However, think about any time you've been in bed with a partner, right? And you say to yourself, oh, here they go. They're gonna do that thing, and I hate it when they do that thing. But they never tell their partner, I hate it when you do that, right? But they move through it, and it's not really fun then, right? And you haven't communicated the things that you really like versus the things that you don't like, right? And you've been able to, make sex much better. And this is a huge component to be able to talk about after an injury with the spinal cord, because sensation is different. The movement is different. Your partner feels different. You feel different to your partner. Moving, patting, positioning, all of those things come into play, right? So you want to be able to make sure that that has been discussed so that they feel confident in their turning, in their patting, in their positioning, to be able to make it feel like it's a part of the process rather than a chore in being intimate with one another. And maybe that's simply just lying in bed and cuddling with each other, right? But lying in bed and cuddling with each other poses problems because if they lay in one position too long, you could potentially get a skin sore, and that can cause even bigger problems, right? So, what do we want? Do we want a relationship? Do we want to date? Do we want to build on a current partnership that we have? Keeping my options open, right? It's the button on Facebook that says it's complicated. Yeah, I mean, these are things that are super important to make sure we meet the client where they're at, meet the patient where they're at, and talk about what are your expectations when you leave here, and how can I help that? Polyamory, it is such a new thing, and you're training like 2 people to do what one person is. So like you've got 3 or more people in a relationship, and making sure everyone understands. And this is like the growing kind of phenomena throughout the country now, and there's lots of talk about, what that looks like for relationships like this. Also, it's complicated, right? It's super complicated, not just from an emotional standpoint, but just from a physical standpoint as well. So know yourself, right? So knowing yourself, exploring your partner. What are your values and feelings? Are you in a relationship? Are you not in a relationship? Is this one of those relationships that you're gonna have multiple relationships because you're trying to figure out? And the one thing with younger kids who have injuries is I explain to them, do you really want to have multiple partners? Because every time you have a new partner, you've gotta educate them. And so thinking about that, also some of my patients think that they are now immune to STIs. And I'm like, that's so not true. Like you've really got to be careful, right? And your symptoms are masked a lot with the spinal cord injury now. So if you do have an STI, you are not going to recognize it as soon. And then it becomes full-blown something else, right? And that's hospitalization and such. So it just becomes a bigger problem. So I really try and emphasize that piece as well. Also, do you want to have children, right? Because you don't know if you can ejaculate. And I have patients who have called me up before and they said, hey, Avery, I have a question. Am I supposed to be able to ejaculate? And I say, I don't know, did you? Like you gotta tell me, because if you did, this is why I tell you, you need to protect yourself, right? Because if you don't want a little one of you running around, then you probably need to think about this, right? Because you don't know it right away. So your emotional capacity for you and your partner to accept where you're at. And so what now? Self-exploration, learn about your body, explore your partner, identify erogenous zones. Erogenous zones change over time, especially with the body and how the body has changed. We know that nerves kind of change and reform, and there's like new highways. And sometimes things that were erogenous previously are not things that are erogenous now, and vice versa. So if there were things that were turn-ons before, they may not be now, or they may be now if they were not. So you really got to explore, and those are things where I can't help you, right? That would be awkward too. But you've got to explore that. Don't just try and jump into having sex or trying to have intercourse, because that's not going to help you. That's actually going to discourage you as an individual, because you don't know enough about you, right? And so figuring that out. So sexual adaptation after SCI is a gradual process that takes psychological and physical adjustments, and this is like an OT thing that I love because I also get to scare our sewing volunteers at the hospital when they see big pink vibrators coming into the room, and I need this on this glove, and they're like, what? So that adaptation is the kind of physical, but that psychological adjustment and talking about it and having those conversations. And the thing I don't like to do is talk about it with just one person in the relationship, right? Sit down with both people, right? Let's talk about this. Let's have a discussion. What are your fears, right? Oh, I'm gonna break him, right? You're not gonna break him. He's probably more stable now than he was before. So, like, you're not going to create any bigger problems, right? So, thinking about all those things. So in spinal cord injury, I mean, we talk about the effects of injury on the spinal cord, and I will get a little bit to the brain injury because that's a little different animal, right? When you work with brain injury. And talking about sexual functioning, because that's usually a lot more from the individual who has not had the brain injury, where you're having a discussion to help them psychologically be prepared for those things. But there's things with spinal cord, level of spinal cord injury, whether you're complete, incomplete, muscle movement, sensation, medical complications, fatigue, injury level, right? All of these things play a big part. So what we do in spinal cord injury, right, is if you've all worked and have a lot of knowledge, we do this really crude cutoff, right? So everything above T12 and everything below T12, and this is what you're going to experience. And I try to help them understand that, like, this is the crude cutoff that we do, but it doesn't mean that it's actually that. Like, there is some give between the two. But erections may be reflexive, weak, or not sustained, right? Erections may not be present. Mental stimulus is not effective. So we are not getting psychogenic erections, right? So anything that kind of from the mind is stimulated. So watching porn, seeing somebody that you're attracted to, those types of things that are started with the mind are not going to help with the erections. And then we're looking at suprapubic catheters, Foley, IC. How are you going to cath? What's going to be the best things for you to do if you've got a catheter that is suprapubic? Like, how are you going to manage that? What do you do with that, right? If you've got a Foley in, what do you do with the Foley, right? How do you manage that? And then, suprapubic catheter, cathing before, cathing after, if possible. So everything below, again, mental effects may help. So they may have the psychogenic erections, but they may not have reflex erections. So reflex erections are kind of the touch, the feeling that you have. And it doesn't necessarily have to be genitalia, right? So like when we talked at the beginning about just holding hands, that's something that can be arousing for people. And so simply holding hands or that physical touch, do they get that? And again, Foley, IC, those types of things. Am I getting it? Thank you. Psychogenic and reflex erections, what we just talked about there. Those are the two types of erections men get. And my most elementary way of trying to explain it is like 100% of an erection allows for both of these occur simultaneously, really without, thinking about it. If you take one away, you don't have an erection that's sustainable, that is a good quality erection. So the rigidity of the penis may not be as good. So there's several components that allow for penetration to occur. And so having psychogenic and reflex erections are something that we really pay attention to, and looking at things like Viagra, Levitra, Cialis, can they help? Allowing patients to trial that while they're in the hospital. that doesn't mean they have to have intercourse. Patients think, oh my gosh, we have to have intercourse in the hospital? That's weird, right? And I'm like, no, it just means like experiment, like masturbate, do something, have your spouse do something that's sometimes just laying in bed together and trialing it at night. And we have little signs that we put on the door that said, hey, this is family time, leave them alone, right? And that's an important indicator for our nursing staff and for our techs to provide that quiet time for them to kind of be with one another. Even if we give them the Viagra and they don't do that, just the ability for them to sit and lie with each other and talk and have those discussions that we talked at the beginning about, right? Like, what are you thinking, right? Does this hurt when I do this? Can I touch you here? Is this sensitive, right? Because you have that zone of partial preservation on patients sometimes, and that sometimes can be very erotic to patients in a moment of heightened senses of sexual feelings. And then as therapists, you might recognize that sometimes they don't like it. It's hypersensitive, it's annoying, but that's probably because they're not attracted to you, right? Or maybe they are and they just don't know it's just not the appropriate time, right? So this is what we talk about. So we use Viagra in the hospital because it is the fastest acting and it has the quickest half-life, right? So it allows for people to have a window of time for us to determine. A lot of times we talk about kids and there's this whole thing. I'm a big pusher for when we have younger individuals for them to be put on a low dose of Viagra or a low dose of Cialis, daily dose of Cialis, just to allow blood flow to the penis so that we don't atrophy, right? And if there's one thing guys don't like is to have atrophy of their legs, we definitely know they don't want it of their penis, right? Because that they think is unattractive. And so blood tissue keeps it healthy, allows blood to flow. There's controversies out there. I'm not a doctor. Some of my doctors agree, some of them don't. I like to tell them, what is it gonna hurt, right? Give them something so that also they're sexually active. So nobody wants to take Viagra and time it and say, okay, we can have sex now because there's kind of that 30 to 45 minute window of time, right? Daily dose of Cialis keeps it in the system. It's just like taking one of their other medications. So we don't typically use Levitra. Herbal alternatives, things like that out there. I just really hesitate on herbal stuff because there can be contraindications to it. You really don't know what the dosage is of it all. So I really try to have patients talk to their physician, their primary care doctor, about what it is they're thinking, why they want to take it. Maybe they talk to another friend who was in a chair that, said, hey, this really works for me, to be able to have that discussion and say, do you think this would work? Do you think this would work for me, doc? So nothing's out, and we do a lot of alternative medications and things like that at the hospital and use them, in different ways. But the herbal medications is really hard, especially now. I mean, there's so much of that going on. Take this vitamin and take this, and you can get it off of TV, and it's really can be harmful. And so I like to stay away from that. Let's start with these. Let's see what we can get first, and then let's move forward, right? Don't panic about the fact that you didn't get an erection the first time you took Viagra. Also, when you take Viagra, you have to stimulate yourself. You can't just sit and watch and think it's gonna pop up, right? You have to do something. There has to be a stimulant behind it. Is it me? Nope. Did it go back one? And, okay. So injections, injectables, non-injectables, we talk about these as well. There's lots of things. Sometimes the younger guys do like it, the injections, because there's like a 20-minute time frame, like a window, which when you look at like the younger adults, 20 minutes of foreplay is about all they want before they want to get into the nitty-gritty and, using injections. There's the Muse. That's a picture of what the Muse looks like. And if there's questions about these, I'm happy to talk to people a little bit about it. Probably not as effective with people who have spinal cord injuries, but that's just a little medication that allows for dissolving in the urethra and opens up that erectile tissue to allow blood to flow in. So someone who's really, really incomplete might benefit from that without a lot. But you get the point, like least invasive first to kind of the most invasive things. Vacuum pumps, penis rings, implants, lots of different things. I don't like to recommend things like the silicone rings because they can pinch the skin. And so I usually have them, there's a leather ring that has Velcro on it that I recommend to patients a lot of times because they can take it on and off pretty quickly and their partner doesn't have to struggle to take it off if they're using one. Just because if they're experiencing AD, you want to remove that really quickly. So autonomic dysreflexia is something that is, for us, is huge to watch out for. And we want to make sure that can be, that whatever is potentially causing it can be removed quickly. And rings like that are very hard. Maybe the one over there on the top, which I refer to as like the bolo tie. But that one kind of slips down and that's a little easier. Pumps are a little harder just because you have to use them. Like, so you use it, you get erect, you quit using it, you engage in intercourse, and then you have to use it again because you lose that erection over time. So ejaculation, 10% of men with SCI can ejaculate, 60 can with the assistance of a vibrator. Vibrators, you will hear that like vibrators being used, but typically vibrators aren't used to get erections. Vibrators are used to be able to get an ejaculate, right? Vibrators might help a little bit with getting erections and providing some stimulus, but really they're used to get an ejaculate. And as I talked about, there's retrograde ejaculation, and if anyone doesn't know what it is, that's when the sperm takes kind of the path of least resistance, moves past the prostate, and then goes up in the bladder rather than out through the urethra. It's not harmful, but what I remind patients is you may you may see your leg bag get cloudy after intercourse, and therefore wait a few times and empties, and you don't probably have a UTI, right? But a lot of them will think, oh my God, I have a UTI. I can't ever have sex again. It's creating UTI. No, it's just that you probably had some retrograde ejaculation. So just helping them past that. So what changes for women? Kind of the same, right? A lot of the same thing. We do the same crude cutoff above and below. But what it is there is a decrease in natural lubrication for the female after a spinal cord injury. And so increasing that lubrication, usually, and we'll get to it, but there's water-soluble lubricants is what is recommended, just because anything that is greasy or oily or creamy or sugary with flavors, if that's what you're doing, then that's hard to get off the skin. And anything that is on the skin and stays on the skin collects and attracts bacteria. And the last thing you want to do is, if you're icing, push bacteria in, and you then really get a UTI. So being aware of that. So water-soluble lubricants, increasing that so that you don't have problems with any skin issues or pain or autonomic dysreflexia. That'll help decrease that. So menstruation for women, there's lots of changes with menstruation, but things normalize. I won't read this to you, but usually within about 6 months or so, things start to normalize for a woman. And I recommend that when women leave the hospital, that they go see their OBGYN. Just to look to make sure everything's healthy, there's not any problems, that they can engage in intercourse or penetration, and that they can feel comfortable about doing that. So women's health is super important when it comes to this. So increased risk of UTIs, leg edema, thromboembolism, autonomic dysreflexia, premature birth, bladder, all these things with pregnancy. Body habitus changes as a woman is pregnant, and making sure their seating and positioning stays there. Being aware of things like their water breaking and not sitting in their cushion too long. That is very important. SCI does not mean the absence in desire, right? And I think these are, for me, huge points. The absence does not mean, or SCI does not mean the absence of desire. The inability to move does not mean the inability to please or be pleased. An absence of sensation does not mean absence of pleasure. And loss of genital function and/or sensation does not mean the loss of sexuality. These are the things that I like to drive with patients. You are still human. We are all human, and therefore we are sexual, right? In some way. It may not be like the person next to you, right? But they're important things to be thinking about. When we go to brain injury, I a lot of times work with the spouse, the partner, on things like, what is it that you're feeling with your spouse who has a brain injury? What are your hesitations? And a lot of times it comes down to affect from the patient and this feeling of not being engaged, involved, feeling like they're being pleasured. Like, I don't think my spouse likes having sex with me anymore. Why? Because their affect is flat. Oh, well, have you talked to them about it? Have they expressed how they feel? If they're able to express themselves in that manner. So that's one of the keys. Also, the opposite, hypersexuality with patients. Using their sexual functioning appropriately, helping to educate patients who are hypersexual on being appropriate with their sexual functioning. So these are just a few things. So sexual adaptation after SCI is a gradual process that takes psychological and physical adjustments. Just some references. I mostly reference my patients and families who I sit and talk with, and they're the ones that educate me. I get stuff from other sources, but mostly it all comes from my patients and families who have allowed me to be a part of that, who have been vulnerable enough to talk to me openly about these things so that I can come out and I can talk and provide education to healthcare workers for you guys to feel comfortable and not feel like it's something that is like weird and taboo to talk about, because it's weird how in the healthcare profession, it's such a taboo thing to talk about. Like, do I talk about it? Should I not? And this hopefully allows for you to feel comfortable to move forward and have those discussions. So that is it. Any questions? Do I have time to take questions? Yeah? Are there questions or concerns? Does anyone? Oh, good, I did a good job. Yeah.
I have lots of clients that don't have heart,
Yeah.
don't have
Yeah.
attacks. And that's going to probably be long term. What do you
Yeah, I mean, if they are wanting to date, right? If it's something they don't want to date and they're just looking to pleasure themselves, is that more the question? Like, how do I pleasure myself? I don't want to deal with a relationship, right? Because that's complicated. So I just want to pleasure myself. What do? Yeah, adapt them. Like, I'm happy to talk to them about, what do you need, a vibrator? We can get you that, right? I'll order those. I have an account to Adam and Eve at the hospital. And I help, because we know insurance isn't covering that, right? So I help them with that. I have rings that come, by the bulk that I provide patients to trial, right? So being open and comfortable and talking about it and saying things like, what do you want? Like, how can I help you? Like, you're interested in this. Let me help you to solve the problem that you think you have, right? And let's equip you, right? Or let me show you what you can buy, to help equip yourself. There's a little book, you can probably get it online, it's called Pleasure Able. And it was a pamphlet that was done by Canada, like the group in Canada. And they have some vibrators on there. They have different tongue vibrators, different rings, things like that you can use. So that's actually a good resource that I hand out to patients for them to kind of look and do some research and figure out what they want. But the one thing I remind them of, don't go and buy everything in the book, right? Like, make sure you have done things first that don't require this, because you may not need any of those things, right? But you have to experience, you have to give your body time to change, adjust. And that's usually over the next 6 months to even a year. But yeah, just sit down with them and normalize the conversation. That's the best thing that we can all do, is just normalize this conversation, not make it feel awkward. Yes?
I'm coming.
Oh.
I'm like an old lady running. Come on.
Who would you say is the best referral, for them to follow up with after they discharge from the hospital if they're not quite ready to talk to us about it yet, or questions come up after they leave an inpatient setting? Is it urology, primary care, or do you have any suggestions for that?
Yeah, I mean, for males, obviously, the urologist is a great starting point for them to be able to talk to them. Hopefully they're all seeing a urologist and they're not, and they've had a little bit of a conversation with their urologist, especially if they're not voiding on their own. Hopefully they're connected. But it's some of my patients who are able to void on their own still have problems with sexual functioning. So they're maybe not seeing a physician as frequently, but I would say they should probably go to their urologist or to their OBGYN and have that discussion about anything, it's amazing to me, and if there's physicians in here, I apologize, but sometimes physicians are the worst people to talk about sex. They're the most uncomfortable. I have the physicians in my office all the time. Can you go talk to them about sex? And they whisper it, and I'm like, why are you whispering this? Quit. Let's talk about it. Let's be open, have the discussion, right? So some of my physicians are better, so they're not all bad, right? But I just don't assume that your physician has had that talk. Ask the physician if they've had the talk and if they feel comfortable having the talk. And if they don't, get them to a urologist. Or my phone line is open too. I'm happy to talk to patients. I get calls all the time from people. There's also a gentleman out there that maybe you've heard of. His name is Mitch Tepper, and he does a lot of discussion on sexual functioning. And he is a quad, and he and his wife have done some, you can look him up online, but he does some padding and positioning stuff, and he shows transfers, how to make a transfer feel normal from a power chair to a bed, or from the bed to the power chair, or use of a lift, right? And so that is also a really good resource for me to just guide people to say, hey, check this guy out. He's a quad, and he's done a lot of discussion about this. So, yeah.
I know like a lot of our patients will say they have a hard time pursuing sexuality when their spouse is the full-time caregiver. How do you address that with patients as far as those boundaries and still having some appeal with it, even when they're doing all the not so pleasant duties?
Right. Yeah, I mean, I think like addressing the idea of are you like the caregiver, that caregiver piece versus like I'm also your spouse and I'm also like sexually attracted to you and I want to have sex, but I don't want to like think of it as like one of my duties as your CNA, your personal home CNA. Like, and that's a very difficult thing to address with them, and being able to make, this is why we try and get patients to be as independent as they can, right? So they can do as much as they can by themselves, right? And we talk about sex and we say, look, you're able to do your bowel program with setup assist, right? So have your spouse set you up, do your bowel program so that they don't have to do it, so that when you guys are intimate, you know, this isn't a problem. But if they can't, that makes it a little more difficult. And how is that going to be something that how do we talk about this with the two of you to allow for you to still feel like it's an intimate moment for you when it's sexual and it's not doing your bowel program, right? I know, I wish I had a better answer for that, but it is the age-old question, is how do we separate it? Because people can't afford home health care 24/7 or 8 hours a day, every day, for someone to come and do that. It's not possible for the majority of, the population. So yeah, good question. Sorry I don't have a great answer. Yeah, but that, it does come to the piece where you need to communicate, you need to talk, you need to discuss what it is we're feeling now in a romantic position as opposed to when we are, what are those cues, what are those things we can say to each other that make this a more special moment. And please don't say those special things to me in my ear when you're doing my bowel program, right? Yeah. Yeah.
Coming back. Hold on, Diane. Not that loud.
One of the things that I end up dealing with is the effect of medications on sexuality, and that oftentimes patients aren't told, oh, this is what's slowing down your orgasm or whatever. Do you deal with that, or who do you have deal with that?
I leave that to the physician to talk about like contraindications of medications. So sometimes I'll give the physician like a recommendation, like, hey, he's 17 years old, he's super sexually active. I'd like to have him on a daily dose of Cialis. However, I know there's some contraindications with some of his other meds. Can you have that discussion with him? Because I don't know 100% all of the time what that is. So I usually will have a discussion with the physician before they go on medication.
Okay, and like psych medications are tremendous.
Yeah, any of their meds, like you don't want to take them off their psych meds if they need it, right? So we definitely have that discussion with which of the medications is better, or maybe we're going to recommend, hey, we need to wait a while until we can shift your meds, right? We need to, back off a little bit. Like, I want you to really spend time exploring your body and doing those things. And then when it feels right, and maybe we can switch some meds that aren't contraindicated with these, sexual functioning meds. We can
Sometimes timing, I think, is an issue with meds too.
Yeah, I mean, like, time is everything when it comes to sexual functioning. Being patient, and we're humans, and we're not good at being patient. We want results all the time, you know? And so, yeah, absolutely, just being patient. But yeah, having those conversations, and I leave the medication contraindication kind of thing with my physicians to have that discussion with the patient about, like, you know, maybe we shouldn't use any of these. Your blood pressure meds are going to be problems too, right?
Or just knowing how long, what's the half-life of the medication, and not trying to have sex when it's the highest in your system.
I mean, we'll have that discussion about, like, when it's best. So a lot of times with Viagra, I'm talking about the half-life of that and how usually, you know, the nicest thing to do, so you're not just, most of my patients, when they're trying it at the hospital, they're so tired from their day of working out and doing everything with therapists. They get into bed, they take their medication, they fall asleep. I go, so you tried your med? And they're like, yeah, but I fell asleep, so I don't know if it worked, right? So I usually say, hey, why don't you take it when you start, like at the beginning of your bowel program? Because your bowel program and your bathing usually takes about 45 minutes, which is about a good enough time for that to kind of kick in and see what results you can get. Yeah, thank you. Am I at time? Or are there more questions? I don't want to take time. All right. All right. Well, thank you very much.
Thank you, Avery. Thank you very much.
We have a little bit of extra time. We're just going to transition the stage a bit, and we'll roll right into our next presentation. Thank you.